So here we are, just running a few minutes late. Lecture number 16. This is the 16th and final lecture of this series. Here we're going to cover the advanced dry needling for the pelvic floor. There's not going to be just tons and tons of information, new information here, except for those specific structures of the pelvic floor that we will investigate dry needling. But with the pelvic floor, there's a lot of other things that we have to take a look at. So we think of the pelvic floor and we think of this sling that holds all of the abdominal contents, and that is very true. And we'll go over each of those, and that's what we're adding today. But we also have to consider that our patient that sees us and considers that they have, whether they may feel that they have some low back pain, they may feel like they've got anything in that area. As we've been through this lecture series, obviously we've seen that there are lots and lots of tendons and ligaments and muscles that attach in and around that pelvic floor region. And so we want to touch briefly on all of those. And I want you to keep those in mind, as they could be contributory, or they could in fact be the actual malady that our patient is dealing with, as opposed to a specific pelvic floor problem. In all odds, with a pelvic floor dysfunction, we probably are dealing with more than one issue at the same time. So anytime I have a pelvic floor patient that I want to deal with, it's dealing with pelvic floor pain, if they're dealing with some incontinence, things of that nature that we would treat therapeutically. We also need to look at everything else in that vicinity. So of everything that attaches in that region, our pelvic floor related structures, we've got the anterior torso, and we'll talk about each of these in a little bit. The rectus abdominis, the transverse abdominis, external, internal obliques, all have an attachment in and around that pelvic floor and can play a role. The pelvic rotator cuff, the glutes, TFL, piriformis. Piriformis isn't specifically included as a muscle of the pelvic floor. I contend, given its origin on the anterior surface of the sacrum, that it really should be. And anytime we're dealing with pelvic floor pain, we need to take a look at the piriformis as well. And then we have the superior inferior gemellus, obturator internus, which we will actually look at a little bit more detail as far as a more unique way to needle that muscle, so that we can affect its an improvement there. It is closely situated to the pelvic floor, and quadratus femoris. Again, a lot of muscles in and around that area, excuse me, that could play a role in what's happening. On the upper leg, excuse me, again, upper leg on the posterior thigh, obviously the tendons of the hamstrings have an attachment very near to the pelvic floor. So is our patient's pain a true pelvic floor, or is it more so closely associated with something there? Similar with the sartorius on the anterior side. Recfem, vastus lateralis, intermedius, and medialis all have a proximal origin there in and around the pelvic floor region. And it's hard for us as practitioners, but it's more difficult for a patient to really isolate. They just know that it hurts down there. And that could be a pain that they're feeling in their perineum. It could be more lateral, either side away from the coccyx, and anywhere from there to the pubis, moving more anteriorly. Similar, the hip adductors, longus and brevis, pectineus, adductor magnus, gracilis, all having that medial attachment that could or could not be associated with problems there. In the pelvic floor itself, we'll look at the Levator A9, which consists of the Pubo Coccygeus, the Iliococcygeus, and the Pubo Rectalis. It's not listed, but we'll also talk about the Iliococcygeus, also known as the Coccygeus, the Ischiocavernosus, the Transverse Perineum, and the Bulbospongiosis, specifically male and female, different approaches on those. We want to consider also our tendons and ligaments. So we talked about the muscles that will attach in that region. Well, there's also, and we've covered these in most of these in the hip lecture, things in the sacropelvic region, the linea alba anteriorly, but moving more to the adductor tendon, the inguinal ligament, interpubic disc. All of these things can have a role of pain dysfunction in that pelvic region. We get to the hip itself. Again, is it a true trochanteric bursa issue, or is it maybe a little bit further into the pelvic floor? And so again, I reiterate, we need to make sure that we're evaluating both the function of the pelvic floor, but also the surrounding muscle and associated tissue that we're dealing with there. Getting into the urinary protocols, I'm sorry, the regional. Well, let's talk about Perineural Protocols first there at the end. We're going to talk about in our treatment protocols specific to the pelvic floor are going to be, we'll discuss neuromodulation. And here we'll look at the Pudendal Nerve, the Tibial Nerve, and then the lower intercostal and iliohypogastric nerves. Intercostals we haven't looked at before, but they're fairly straightforward. The iliohypogastric we have looked at before. And then because of their relationship and their location around that pelvic ring, we'll also look at our superior and medial cluneal nerves, lateral cutaneous, iliohypogastric, anterior as well, lateral femoral cutaneous, the genitofemoral nerve, obturator, and then the muscular branches of the femoral nerve, and then posterior femoral cutaneous nerve. So we've got a lot of other nerve pathways in that area as well that we need to evaluate those and see if there's a sensory deficit, if there is a motor response that we're not getting what we need to. So we want to look there at the perineural protocols as well. For our regional protocols, we'll get down and dirty with what we're talking about here with the pelvic floor. We want to look at a protocol for urinary urgency and frequency and incontinence. We treat incontinence through dry needling very frequently with outstanding results. And we'll look at some research that was done recently on a protocol by a urologist. We'll look at urinary and fecal incontinence as well, then just general pelvic pain. Abdominal pain as well, the slow colonic movement. And then we also, because it's in that pelvic ring area, we also need to consider our previous protocols at the thoracolumbar junction, our lumbosacral junction, sacroiliitis. It's because of where those muscles do come around and form part of that superior most aspect of the pelvic ring. We do have to look at sacroiliitis, our LSP junction, sciatica, piriformis syndrome, troch bursitis, IT band syndrome, anterior hip OA. Again, it's usually very specific to that anterior hip, but we need to make sure that we're evaluating whether or not there is a component of the pelvic floor as well. Again, also the adductor strain or the hamstring strain. We're going to try to stay focused as much as possible on what we're looking at as far as the pelvic floor, as far as new content. So for our supporting evidence, I wanted to bring up a study. This came out in 2015. This was an update done by Gupta, and it was percutaneous tibial nerve stimulation and sacral neuromodulation. And so they talk a little bit, neuromodulation being an important treatment modality for a variety of pelvic floor disorders. Currently, there are 2 approved methods for delivering this therapy. One would be percutaneous tibial nerve stimulation, which our dry needling protocol that's been developed is a little bit different than their approach. They just do their and we'll get into it more detailed, but just on the foot itself, we've adopted that and changed that a little bit differently. The other way is through sacral neuromodulation, which they use an implanted device stimulating the S3 nerve root and can show improvement in symptoms. Their conclusions were that the percutaneous tibial nerve stimulation and the sacral nerve stimulation, they're both effective for the treatment of these pelvic disorders, including overactive bladder, non-obstructive urinary retention, fecal incontinence, and pelvic pain. The percutaneous tibial nerve stimulation, it has the advantage. It's an office-based procedure. It's although we are using 2 needles on each side, it's relatively non-invasive compared to the implanting of the stimulation device by the sacral neuromodulation. On sacral neuromodulation, they tended to see that they would get improved benefits as long as that unit was running, but it didn't seem to have much longer-term carryover. Again, the bigger thing is the more minimally invasive treatment approach through the tibial nerve neuromodulation. But we'll get into that more specifically when we get down to our treatment protocols. Okay, so I'm not going to go over the 3D kinetic screen. However, if there is a pelvic floor dysfunction, still a good approach to look at things that are in and around the pelvic ring, the muscles of the hip, the lumbar spine, hamstrings, quads, all of those that have a proximal attachment in and around that pelvic ring could play a role in our pelvic floor dysfunctions. And so going through this screening process may not be a bad idea to add to your evaluation of this pelvic floor patient. Moving on to the muscles of the anterior torso, rectus abdominis, transverse abdominis, external internal obliques. I'm not going to go into all the great detail that we have in our previous lectures. We've already got that, and you have reference to that there in the lecture and in the app as well. But obviously you can tell rectus abdominis does have that terminal insertion there very near the symphysis pubis. For our treatment approach, we just simply drop our needle into that rectus abdominis. It can be done up high, closer to the rib, or it can be done a little bit lower. In this case, when we actually use our rectus abdominis for our treatment, it'll actually be this lower treatment placement below the navel. For the transversus abdominis, external, internal oblique, this is the one we're in sideline, and then we just bulk that muscle together, and we needle through that between the iliac crest and the lowest rib. We can needle all of those, but again, as the diagram, excuse me, the pictures indicate, it does have also an insertion low at the crest of the pubis. In the lumbosacral, all of these, the longissimus, the multifidus, iliococcages, a lot of these muscles do have that deep termination there between the PSIS and approximating onto the sacrum. So because of their proximity, we definitely need to make sure we look at that. Do a nice palpation assessment and a screen to rule out that as a specific underlying cause. It fairly frequently can be a true pelvic floor issue, as well as this lumbosacral piece. Interspinalis, again, I'm not going to take a ton of time here on the spinalis. We looked at in our introductory lab, our first 4 lectures. Just needling in between the spinous processes. Similar for longissimus and multifidus, we're going to come to 1 finger breadth lateral to the superior aspect of the spinous process, and then about 15 to 20 degrees are medial and inferior angulation landing down on the lamina. The iliococcages lumborum, if you recall, that's the muscle. A little bit further laterally, we're going to make that lumbrical grip to grasp that muscle, so that we can then needle through that almost parallel to the rib cage to land into the muscle of the iliococcages. Again, no backdrop on that. PSIS, very common point of tenderness with this lumbosacral issue. Also, because of its proximity, in our picture, we can see piriformis slightly distally, which I contend still plays a role whenever we're dealing with the pelvic floor. But just slightly further distally, there's coccygeus, or the Iliococcygeus, and then further is the Iliococcygeus, which those can definitely both be needled in a couple different directions. QL, again, because of its attachment onto the pelvic ring and its ability to radiate pain a little bit more internally and a little bit deeper, frequently can be confused for true pelvic pain, or it can be seen in conjunction with pelvic dysfunction. Similar psoas major, and we'll look at QL psoas major as well as iliacus. Again, inside that pelvic ring itself. So with a complaint of pelvic floor dysfunction, whether coming from the urologist, coming from the gynecologist, whoever it's coming from, we need to make sure that we're looking at all of the other pieces as well and not excluding those as potential areas of dysfunction. Serratus posterior inferior sits a little bit higher. It might be involved. I think it's rarely involved, but given its location where we're going to needle, odds are we're going to needle through that anyway to give us some change there. The muscles associated with the pelvic floor, the glutes, TFL, piriformis, and the standard approach on the deep hip rotators. So just briefly covering this, our gluteus maximus, we've got that center line between the superior apex of the greater trochanter, the PSIS, with that needle angled directly toward the ilium as a backdrop. Very frequently, this is our key muscle or needle approach in that posterior lateral hip. With this single needle placement, we get gluteus maximus, we get medius, and we get some of the fibers of gluteus minimus as well. So this is usually one that we rarely want to avoid in our treatment approach. Medius, we're going to take a little bit further. This point does isolate it specifically, coming up the TFL, going to move over 3 finger breadths and down 2 to 3 to land specifically into the fibers of gluteus medius. For minimus, again, we're going to take that TFL between the superior aspect of the greater trochanter and the iliac crest. Again, that fiber is palpable as we move up right there, so we can take that midpoint and direct it completely lateral to medial to land into the fibers of gluteus minimus. TFL is going to be a similar needle approach that we used with gluteus minimus, and a direct approach is identical, but we can also do a threading approach where at that same location, we'll use a hand on one side, we'll just grasp that and then thread through that TFL to get a more surface area of that muscle to elicit that change. Again, all of these muscles are playing a role in around that pelvic ring. We're operating on the assumption that the physician has made a proper diagnosis of pelvic floor dysfunction. We need to still do our piece, come back, look at the other muscles that are involved. Again, rarely do we see whether it's a knee problem, a shoulder problem, anything isolated to just a single group. Usually there's something else going on as well. So the muscles of the pelvic rotator cuff probably very frequently involved here. Again, piriformis, we don't see it from this view. We could look at it on the anatomy app, but with its anterior placement on the sacrum, definitely forms a superiormost aspect of that sling of the pelvic floor. Then we get into the deep rotators. If you recall, this is, and we'll come back to obturator internus in a moment. On those, this is the one where we came just a little bit distally from our needle placement for piriformis, and then we just did some periosteal pecking deep into these rotators to end terminally into quadratus femoris. For excuse me, for obturator internus, we're actually going to take that from a different approach, and we'll cover that in just a bit. For the posterior thigh here, semitendinosus, membranosus, biceps femoris, and also the adductor magnus, all attaching either on that pubic ramus or onto the ischial tuberosity itself. Again, frequent area of concern with pelvic floor dysfunction. A lot of times we have a patient, maybe they spend a lot of time sitting at their job. Maybe there's a coccygeal malplacement. Maybe it's tilted a little bit too far anteriorly, too far posteriorly. We can see and feel some muscle tension as a patient in that regard. And because of the proximity here of the posterior thigh muscles, we want to make sure that we, if we're uncertain, we want to be able to needle those, roll those out. Dealing with the hip, we talked about needling the muscle both distally or proximally, and as far as needling that common tendon for the hamstrings right there on the ischial tuberosity. Again, here demonstrating our distal needling approach. If there is a proximal attachment problem, if there's a high strain in the hamstrings, definitely we want to needle those further distally, either mid-belly or even further down at our distalmost aspect here. But we're probably also going to need to go hit them right off the ischial tuberosity in the tendon piece itself. Again, same thing with bicep femoris, both distally and then proximally. And same for adductor longus, magnus, gracilis. When we dealt with the advanced tip, we looked at needling that in sideline and catching those three locations, 4 finger breadths or a palm breadth distal from the symphysis pubis and getting a good response out of those. So we'll move further into interlateral thigh. Again, obviously, sartorius. It's a little bit more superior coming off of the ASIS, but it can be associated as far as a diffuse pain. If we can isolate that and find out that that is in fact the patient's problem, then perfect. We can stay away from that pelvic floor. And let's be honest, the very last thing we want to do with any patient is to have to needle into the muscles of the pelvic floor. If we can find our issue to be somewhere else in tissues a little bit further distally, more proximally, more superficial, then that's definitely the way to go. The dry needling of the pelvic floor is quite effective. It's not as, we consider dry needling of the hands, of the feet, of the face, one of the most challenging things that we can do, simply because it's very tender locations. Common thought would be that the perineum, the pelvic floor, would be even worse than that, and it's really not. It's more that awkwardness between patient and clinician of being in a vulnerable location, vulnerable position, which we try to de-emphasize that with a nice sideline position for the lower side of that pelvic floor. Again, rec fem with its more proximal location, similar to lateralis, it can be needled up higher on the femur itself, intermedius and the medialis. So all of those to be taken into consideration for dealing with the pelvic floor. Again, we want to rule out any other issue that we can before we specifically go target the muscles there of the pelvic floor. Again, we'll look at the adductors, pectineus, adductor magnus, and gracilis, all there with the attachment there on the pubis. Because of its location, definitely we want to consider if that's something we need to address. Pectineus, and we've dealt with this on the advanced hip, because it is absolutely on the pelvic ring. It's anterior. It doesn't specifically, most of these don't specifically meet the definition of pelvic floor, but I can tell you with my own body, if there's another issue that's causing my discomfort, let's deal with those first before we go and needle my pelvic floor. So that brings us all the way here now to the actual muscles of the pelvic floor. The Levator A9, which consists of the Pubo Coccygeus, the Iliococcygeus, and the Pubo Rectalis. Then we have the Coccygeus, the Iliococcages, the Transverse Perineum, and the Bulbospongiosis, which we'll have a male and female version with that. But we'll also look, it's not listed here, we'll also look at a unique approach to needling the abductor internus because of its location. So in the levator ani itself, it's a broad, thin muscle group. It's situated on either side of the pelvis. It's formed from those three muscle components: Pubo Coccygeus, Iliococcygeus, and Pubo Rectalis. And we'll go into those in detail in just a moment. Coccygeus, also known as Iliococcygeus, it's a triangular shaped sheet of muscle. It's located posterior to the levator ani muscles in the pelvic floor. So in this diagram, here we have the sacrospinous ligament. It's not that it has the exact footprint as does Coccygeus. In this particular picture, Coccygeus, I have it removed, but it has this same footprint as the ligament itself does. So the Coccygeus, together with the levator ani, forms the pelvic diaphragm or the pelvic floor. And we'll look at it in a moment. If the piriformis were included here, we would see it just proximal or cranial to Coccygeus, with attachment here or origin on the anterior aspect of the sacrum. And so because of that, forming that superiormost aspect, I can really consider the piriformis as part of the pelvic floor as far as treatment anyway. So the Pubococcygeus, picture on the left, we're looking at it from cranial to caudal. So we're looking above down into that pelvic ring. On the picture on the right, we're just looking at that muscle isolated from the other muscles of the pelvic floor. Its origin, actually, I think what we will try to do is jump over to our 3D anatomy app. I'm going to try to do that. Again, having some technical difficulties, but let's see if we can do that. So actually, let's do this an easier way. Let's talk about these, and then we'll come back and do that all at one time. So Pubococcygeus, its origin, the posterior aspect of the body of the pubis and the tendinous arch of the levator ani. So you can see that tendinous arch right here as it separates these muscles, obturator internus sitting here, and then the muscle of the levator ani sitting on. It's also sharing that attachment. Excuse me. It inserts into the coccyx, the pubococcygeal tendon, perineal body, which we'll talk about, the lateral walls of the vagina in females, and the prostate in males. It's innervated by the nerve to the levator ani muscle, which is inferior anal nerve, perineal nerve, which are branches of the pudendal nerve. Its action, it provides structural support to the adjacent pelvic structures, urinary fecal incontinence. Its fibers and all of the muscles in the pelvic floor have a similar function here. Its fibers are capable of maintaining a tonic contraction at rest, which relaxes during micturition and during defecation. So we'll come back to all of those in a bit. The Iliococcygeus, again, we're looking at it from a cranial to caudal look on the left-hand side, and a caudal to cranial view on the right-hand side. The Iliococcygeus, its origin is the ischial spine and the tendinous arch of the levator ani. So that tendinous arch is right here between coming off of the where the coccygeus attaches on the spine here, but it also attaches onto the coccyx itself on the distal part. So right above, we're going to see the sacrococcygeal junction, and then distal to that is where we'll see our Iliococcygeus. That sacrococcygeal junction is what helps us separate the coccygeus from the Iliococcygeus. So we find our sacral horns, and that'll let us drop off into the specific muscle, coccygeus. We go further distally onto and we're going to do it actually differently, but in prone, it can be done off of the coccyx itself. But we'll find a different and easier way to do that a little bit further into the muscle. So that's its insertion into the coccyx, the iliococcygeal raphe, and the anococcygeal ligament. Again, its innervation is the nerve to the levator A9 muscle. And again, similar action, just providing structural support and maintaining that tonic contraction at rest, which can relax during micturition and defecation. The Pubo Rectalis is its origin, the posterior aspect of the body of the pubis, and its insertion, the fibers just surround the posterior aspect of the anorectal junction. So it sits here on the body of the pubis, and it basically creates a sling around that anorectal junction. Its innervation, again, the nerve to the levator A9 muscle, again, part of the Pudendal Nerve. Action, again, similar. It's support to the adjacent pelvic structures, and here just fecal incontinence, and its fibers, again, capable of maintaining that conic contraction at rest, which can relax during defecation. The coccygeus, we'll look at it again. Here we have that sacrococcygeal junction at the sacral horns, and that muscle just splits right between the distal half of, or the lower part of the sacrum and the upper part of the coccyx, with lower that now we see the Iliococcygeus coming directly off the distal part of the coccyx itself. The coccygeus, its origin, sacrospinous ligament and the ischial spine. It's inserts into the lateral margin of the coccyx and the lateral border of the sacrum. Innervation, the pudendal nerve, sacral nerves, S4, S5 or S3, S4. Its action, it's going to pull the coccyx forward after defecation, closing in the back part of the outlet of the pelvis. So given its location there, we'll assume that action both for the coccygeus and to a certain extent the Iliococcygeus. So it will relax during defecation, open up that canal for the defecation, and then when completed, it can maintain that tonic contraction to close that cavity off a little bit further. The ischiocavernosus. So on the left, excuse me, on the left is representation of the male, on the right is representation of female. For the origin is going to be off, in both cases, off the ischial tuberosity, and in the female, it's going to insert into the crus of the clitoris, and the male, the crus of the penis. Innervation here is the perineal nerve, again, part of the pudendal nerve. And its action, it assists in either erection of the clitoris in females or the erection of penis in males. So the remainder of these are more our genital. The previous were more about control of the pelvic floor itself, and these we'll consider outside the pelvic floor, but still part of both sexual arousal and our urinary component. Well, we'll get to a little bit, primarily urinary. So that's ischiocavernosus, again, laying right there on the ramus of the pelvis. Is there, again, a lot of good information here. Feel free to go back and review all of this. Again, ischiocavernosus, primary function is assisting in erection of the clitoris and the penis. For the transverse perineum, first we need to discuss the perineal body. So on this picture, again, male is on the left, female is on the right. The white area right in the middle between the anus and the vagina, or here between the anus and the penis, is what's called the perineal body. And basically the perineal body serves as an attachment point for a lot of our muscles in this region. Transverse perineum being the primary one. For that, we have two separate muscles with the transverse perineum, both on both the left side and the right side. We have the superficial and the deep. We needle them the same. We don't isolate one over the other. So for the origin of our superficial transverse perineum, it's on the ischial tuberosity and the ramus of the ischium. For the deep transverse perineum, it's on the internal surface of the ramus of the ischium. So it just drops down a little bit further here for the deeper muscle itself. They both insert into the perineal body, and again, innervated by the perineal nerve. And here the reaction is purely stabilizing that perineal body and providing some milder structural support to the adjacent pelvic and the perineal structures. Basically, it's there to stabilize that perineal body on a medial lateral or away from midline position. It's just stabilizing that stabilizing structure. And then for the Bulbospongiosis, in older texts, it's referred to as the Bulbo cavernosus. I think everything is transitioned basically at this point to Bulbospongiosis. Again, male on the left, female on the right. For the origin, for the female, it's on the perineal body. So female, obviously, on the superior, male on the upper, male on the lower piece here. Again, female perineal body on the male. The origin is the perineal body and the median raphe on the ventral aspect of the penis. So it has a little bit more attachment here. If I could rotate that, we'll look at that in a minute. You can see that a little bit better. Insertion, females onto the perineal membrane in the corpora cavernosa of the clitoris. And so it's going to come all the way up with an attachment here. Again, similar, almost identical attachment as ischiocavernosus, more laterally. For the male attachment or the insertion is the perineal membrane in the dorsal aspect of the corpus spongiosum and the corpora cavernosa of the penis. And so, again, similar to ischiocavernosus, both are their action, in this case, stabilizing perineal body. It expresses secretions of the greater vestibular glands and assists in erection of the clitoris in the female. For the male, stabilizing the perineal body, expels urine and semen from the urethra, and it assists in erection of the penis. So again, Bulbospongiosis and ischiocavernosus definitely playing a big role in the sexual function. So person coming, pelvic floor issues, as you talk to them, there may be some sexual dysfunction. We're not sex therapists. However, we are capable of treating these issues. And so these definitely would be our muscles that we want to look at for dealing with that. So let's come down. All right, let's do this all at one time here. Let me come over and share here. Okay. So let's start with let's just start with the Levator A9 itself first. I'm going to make this a little larger. Let me get rid of that. So the Levator A9 we discussed, we're going to come and we're going to look at it from a superior aspect. One of the first that we want to look at, the Pubo Coccygeus. As you can tell, it has its origin, posterior aspect of the body of the pubis. So you can see its origin here. And as far as insertion, again, a left side, a right side, but onto the coccyx, the Pubococcygeus tendon, right up here. The perineal body, you can't see it from this side, but Pubo Rectalis is in the way. Everything seems to have an attachment to the perineal body. Very important structure right there. The lateral walls of the vagina in the females and the prostate in males. And so there we have our Pubo Coccygeus. I'm going to, let's see if what fading will do for us. Just fade that side. Okay, so we'll move around and let's talk about Iliococcygeus. We'll look at it from inferior first. And actually, I'm going to, so I can manipulate this a little bit better. If you've never done a Zoom coming off of two laptops at the same time, I highly recommend it. It's a lot of fun. So, Iliococcygeus, we see here its origin on the ischial spine and the tendinous arch of the Levator A9. So, the ischial spine and then this tendinous arch of the Levator A9, which is coming all across right here. It's kind of faded at the moment. Inserts in the coccyx and the iliococcygeal raphe and the anococcygeal ligament. So all along from the coccyx all the way down. If we look at from here, let me move now to the Pubo Rectalis or the Pubo Analysis. Again, its origin is onto the posterior aspect of the pubis, and then it does have an attachment onto the perineal body, but it basically just comes around and acts as a sling around the anorectal region. So it just provides that extra support there. And it helps with fecal continence. All right, so let's move from here. Get my library back up. And then let's look at our urogenital. I've got two here. Why do I have two? I don't know, but we'll start with this one. So on the urogenital muscles for the female. First, I mean, three basically, four if you consider transverse perineum having two. So let's talk about transverse perineum. So you can see that there's a superficial and a deep grouping there. There's not a lot of difference in their origin or their insertion. We're soft fit to have a superficial and a deep, so we're going to deal with both. But again, their main primary objective is to stabilize that perineal body from lateral or migration away from midline. So if you are having a patient with a significant amount of true pelvic floor dysfunction, that may be a nice starting spot to normalize what's happening there. Again, with so much attaching onto that perineal body, that may be a very good starting spot. From there, we move to the specific muscles of, number one, ischiocavernosus. Again, coming off of the ischial tuberosity right here, and then traveling around to attachment to the crus of the clitoris right there. And that's, we will go over how to needle that. We'll look at the male in a little bit. Ischiocavernosus sits a little bit more internally behind the ramus of the pubis here than does the male. The male is a little bit easier to access, but one of the many distinctions here. We looked in specifically at Bulbospongiosis. Again, we have our primary origin coming off of the perineal body. And again, its attachment to the crus of the clitoris. Again, both of these muscles assisting with sexual function, with, again, erection of the clitoris. So that may be something after discussion with your patient that if that's an appropriate treatment approach, that these two may be something we need to consider in treatment. And we'll go over how to do that in just a bit. Back to our library. Let's come back now and look at the male. closing that off. Okay, so when you look at the male and the female side by side, one of the biggest things that you'll notice is the, sorry, have to double check that I am recording. Perfect. That would have been disappointing. Is the angulation of the ramus of the pelvic bone itself. With the male, it's much more narrow, and for the female, it obviously widens up a little bit for that birth canal, or presumptive. That's the reason. That makes it a lot more tolerable than if a male were going to try. Anyway, so we first start off again very similar with the perineal transverse perineum. Again, see if I can rotate this without going too crazy here. So again, superficial, deep transverse perineum. We will go over specifically how to needle into that. Again, if there is some question about muscle tension in that pelvic floor, anywhere that it's going on, there's going to be something that's attaching to that perineal body, in which case we need to look at the transverse perineum to consider what role it may play in normalizing that tissue. We zoom back out, again, for the male, the ischiocavernosus, sitting laterally. Again, coming off of the ischial tuberosity, the more anterior aspect, and then with its migration anteriorly onto the crus of the penis. Again, it's a little bit more prominent, whereas the female sat, the ischiocavernosus sat a little bit behind the ramus here, and the male a little bit easier to access with the bulbo. So that's ischiocavernosus, Bulbospongiosis. My computer catch up. Look at it on this side. So again, its attachment or its origin, again, the perineal body, and then again, it's inserting into dorsal aspect of the corpora spongiosum and the corpora cavernosa of the penis. So again, for the male, after questioning and discussing if there are issues related to erection, to stimulation, these are two muscles that we can't have a direct impact on those. And we'll, like I said, we will discuss needling all of these in just a moment. All right, now with a little luck, I'll stop that share and move from there back to, there. Okay, so let's talk about treatment. We'll start with the Pubococcygeus. So as late as today, I was asked in our pelvic floor component of our lab, will we be actually dry needling the pelvic floor? We're going to simulate this. If I get a group of students who want to get together and actually do dry needling on the live subject of the pelvic floor, we can absolutely arrange that. In our purpose here, we're gonna simulate what's going to happen. It's easier for patients. I'm sorry, it's easier for our students and the models that we're going to do this with. So I can allay your fears right now and trepidation. We're not going to have to drop trowel and get down to the nitty gritty on this, but you will walk away fully aware of how to dry needle this. Again, if a group gets together and we can discuss it, we can absolutely make arrangements to do it, dry needling of this pelvic floor live on a live subject. So for the Pubococcygeus, again, we have our origin, our insertion, innervation, our action. For dry needling, most of what we're going to do here is in relation to the perineal body. So for the Pubococcygeus, we'll talk about our sideline positioning. And I've got a little clip that talks about our positioning in just a moment. So actually for dry needling of the pelvic floor, one of the first issues we want to deal with is that of patient positioning. We frequently, when we think of dry needling the pelvic floor, the first thing that pops into our mind is are we going to place our patient in the gynecological stirrups for treatment? And well, I guess that could be done. Absolutely not the way to do that. We want to stay in the least vulnerable position as possible. So sideline actually presents us with a really easy access. And again, it's much less vulnerable position for the patient. So what we do is our mat side is actually going to be our treatment side. And we're just going to flex the hip and the knee of the opposite leg up, place it on a pillow. And as you can see, when we look at our model, it's going to give us really nice access to the entire pelvic floor on that mat side. So very frequently we are going to deal with, or more often than not, both the mat side as well as the sky side. So treatment side is always going to be the mat side surface here. And to go bilaterally, quite honestly, all we're going to do is flip to the other side, position in the same orientation, and then we can treat the other side of the pelvic floor as well. So great positioning for dry needling of the pelvic floor. So for this, we're going to be in that sideline position. Our treatment side is going to be the mat side. Needle length here is going to be 30 to 40 millimeters, and that's going to be determined by palpation. So we want to palpate that pelvic floor. We're going to have them perform a pelvic floor muscle contraction. So for our needle location, it's going to be 1 finger breadth lateral from the midpoint between the perineal body and the anal sphincter. Our needle inclination is going to be 45 degrees, both cranially and anterior relative to the treatment table. We've got to get through some tissue to get down into that, but you're going to use your manual palpation as your patient contracts to determine what that appropriate depth is. Our precautions here in most everything in the pelvic floor is the rectum, the vaginal canal, the urethra, the inferior rectal neurovascular bundle. And so again, definitely an advanced technique. If you're uncertain, you definitely don't want to take and insert a needle directly into the cavity there. For the Pubococcygeus, here our patient is going to be in the standard sideline treatment. Our needle length can be either from 30 to 40 millimeters. This is going to be determined by palpation. There is no backdrop here, and our precautions are for the rectum, the vaginal canal if appropriate, the urethra, inferior rectal neurovascular bundle. So in sideline position, the treatment leg is mat side. The top side leg is just flexed at the hip and the knee to be out of the way. We're going to palpate the medial side of the ischial tuberosity. Here we're going to be adjacent to the perineal body, which perineal body sits between the rectal orifice and the vaginal orifice. So sitting right here. We're going to confirm our muscle depth here with pelvic floor muscle contraction. And then 1 finger breadth lateral from the midpoint between the perineal body and the anal sphincter. We're going to needle 45 degrees both cranially and anteriorly relative to the treatment table. So 1 finger breadth lateral from the midpoint between the perineal body and the anal sphincter, and then 45 degrees both cranially and anteriorly relative to the treatment table. Okay, so that is Pubo Coccygeus. Obviously, unless you can identify it as a unilateral problem, which sometimes you can, you're going to have to treat one side and then reposition your patient to the other side so that you can treat the opposite muscle. And that applies across all of the muscles here in the pelvic floor. Our alternative is to place our patient in, again, the gynecological stirrups, which is not anything that we want to be involved with. Much more relaxed and non-threatening position in that sideline position. There's only one position where we will get into the supine position, that's going to be for Bulbospongiosis, but we'll get back to that. Okay, we move on to the Iliococcygeus. Again, its origin, the ischial spine, the tendinous arch of the Levator A9 inserts into the coccyx, and its supportive ligamentous structures. Innervated by the nerve to the Levator A9 muscle or the Pudendal Nerve, and its action, again, providing that structural support to the adjacent pelvic structures, urinary, fecal incontinence. Its fibers are capable of maintaining that tonic contraction at rest, and that relaxes during either micturition or defecation. So here we're going to be in that sideline position. Needle length again is going to be 30 up to 40 millimeters, probably closer to 30. So much of that depends on the habitus of your patient. Again, sideline treatment leg is mat side, top side leg flexed at the hip. We're going to palpate the medial side of the ischial tuberosity again, adjacent to the perineal body. We're going to confirm that muscle depth again with the pelvic floor muscle contraction. And in this case, we're going to go 2 finger breadths lateral from the midpoint between perineal body and the anal sphincter. And again, we're going to be needle both 45 degrees, both cranially and anteriorly relative to the treatment table. So the big difference between Iliococcygeus from the Pubococcygeus is we're going to be, instead of 1 finger breadth lateral, we're going to be 2. For the Iliococcygeus, again, our patient is going to be in a sideline position. Needle length can be 30 up to 40 millimeters. There is no backdrop here, and again, similar precautions: rectum, the vaginal canal, the urethra, and the inferior rectal neurovascular bundle. Again, in sideline position, the treatment leg is mat side. The top side leg is flexed at the hip to be out of the way. We're going to palpate again the medial side of the ischial tuberosity, adjacent to the perineal body. So here, perineal body, we're going to palpate here the ischial tuberosity. We're going to confirm our muscle depth with the pelvic floor muscle contraction again, and then 2 finger breadths lateral from the midpoint between the perineal body and the anal sphincter. 2 finger breadths lateral from there. We're going to needle 45 degrees both cranially and anteriorly relative to the treatment table. So ischial tuberosity, perineal body, anal sphincter, midpoint here. Then we're going to be 2 finger breadths, and then we're going to be 45 degrees both anteriorly and cranially. Okay, and then on to the Pubo Rectalis, which is the smallest and the most proximal of the Levator A9. Here again, its origin, posterior aspect of the body of the pubis, and insertion and fibers surround the posterior aspect of the anal rectal junction, and it also has some attachment there onto the perineal body. Innervated by the nerve to the Levator A9 muscle, inferior anal nerves, and the perineal nerve. Again, the branches of the Pudendal Nerve, and it has that same support. Its fibers capable of maintaining that tonic contraction at rest. In this case, it relaxes during defecation. So for treatment here again, the needle length is 30 millimeters or less. There's no backdrop on any of these. The precautions, again, rectum, vaginal canal, urethra, inferior rectal neurovascular bundle. Again, treatment leg is mat side, top side leg is just flexed at the hip. We're going to palpate again that medial side of the ischial tuberosity adjacent to the perineal body. We're going to confirm muscle depth again with the pelvic floor muscle contraction, then immediately adjacent to the anal sphincter. We're going to needle 45 degrees anteriorly, parallel to the treatment table. So much more superficial than as with the other muscles of the Levator A9 that are creating that cranial more piece of that sling. Here it's going to be a little bit more superficial. So we're going to stay parallel to the treatment table and in a little bit of 45-degree anterior inclination from there. And again, we definitely don't want to be midline. It doesn't have to be a full finger breadth lateral. So maybe a half finger breadth away from that midline. Adjacent to the perineal. For the Pubo Rectalis or the Pubo Analysis, position here is going to be sideline. Needle length is going to be no more than 30 millimeters, should be a little less than that. There is no backdrop here. Again, our similar precautions
for the rectum, the vaginal canal, the urethra, and the inferior rectal neurovascular bundle. Again, going to be in the sideline position. Treatment leg is going to be mat side. Top side leg is just flex at the hip and the knee. We're going to palpate the medial side of the ischial tuberosity, again, adjacent to the perineal body. So perineal body, ischial tuberosity here. We're going to confirm our muscle depth here with a pelvic floor muscle contraction, and then immediately adjacent to the anal sphincter, we're going to needle 45 degrees anteriorly, parallel to the treatment table. Again, a 3 centimeter needle, 1 finger breadth lateral, so just adjacent to 45 degrees anteriorly, and we're going to be parallel to the treatment table. Again, the Pubo Rectalis is just a loop around the anal sphincter to help assist in closure, and so we have to be fairly close to that. Again, 1 finger breadth away from anal sphincter.
So this picture this frame is a really nice representation of differentiating between the muscles of the urogenital area, urogenital area, the fecal area, and the pelvic floor itself. So we consider those muscles of that pelvic floor just creating that sling of support. And then we have what we're going to get into next, which are going to be the muscles of the ischial cavernosus, the Bulbospongiosis, and then we'll also look at the obturator internus. So this is basically just a modification of how we had needled the obturator internus previously. As you recall, we have all of those deep hip rotators, that very small tendons is there and muscles as they're coming over to attach onto the femur itself. Well, here we have the opportunity to needle into the obturator internus a little bit more effectively. I've taken everything else out, but assuming that the femur, the ball, the neck, the tuberosity out here, and this is obturator internus, with this small tendinous piece coming way over here. Well, when we're trying to do this needling for the hip, we're just hoping that we're actually hitting onto this tissue as well. Well, you can tell that's a very thin slip. But as we look more internally, we see that muscle actually has a fairly large footprint. And I'm going to rotate a little bit here. Actually, let's rotate. Let's assume our patient is laying mat side, and we want to treat this mat side area here. Well, as you can tell, that obturator internus has a pretty big footprint in there, and any dysfunction there can easily be mistaken for true pelvic floor issue. Matter of fact, there is what's called the pudendal canal, or the Alcock's canal, that we'll talk about in a bit, where the pudendal nerve actually lays very similar, very close proximity to obturator internus itself. So we want to be able to effectively needle that muscle a little bit better than taking our chance that we hit it whenever we're out here laterally. Odds are very small that we actually hit that there, but right here, man, we've got a nice footprint. We can hit that thing right there. All right, back to the obturator internus. Let's come down. All right. So its origin, obturator internus, is the obturator membrane. It's the bone around the obturator foramen on the internal surface of the pelvis. It inserts into the medial surface of the greater trochanter above the trochanteric fossa of the femur. Again, obviously, way out here, we might get lucky and hit that. We might not. Better chance, let's catch it below. Innervation is nerve to the obturator internus, and its action is the external rotation of the thigh and abduction of the thigh when the thigh is flexed, or when the hip is flexed. So for needling here, we're going to be sidelining again. Needle length is going to be 40 millimeters or 4 centimeters, and there's really no backdrop here. Our precautions, again, same: the rectum, vaginal canal, urethra, inferior rectal neurovascular bundle. So for the procedure in sideline, the treatment leg, it's mat side. The top side leg is just flexed at the hip out of the way. We're going to palpate again that medial side of the ischial tuberosity adjacent to the perineal body. We're going to needle down to the medial aspect of the ischial tuberosity. So we're actually going to land, if you can see on the picture, we're actually going to land on the ischial tuberosity itself, there on the medial aspect. Then we're going to redirect, and go 45 degrees cranially to land into that obturator internus muscle. And that is we have much more surface area. We can elicit a change right there.
So here, a modification of our treatment, dry needling treatment of obturator internus. Here, this will be more into the bulk of the muscle belly of obturator internus, as opposed to with a pelvic rotator cuff, where we needled the smaller muscular tendinous junction as it's attaching onto the femur itself. Here, our position, we're going to be side lying. Our needle length will be about 40 millimeters. The backdrop is either none or down to the ischium itself. Again, precautions here for the rectum, the vaginal canal, the urethra, the inferior rectal neurovascular bundle. So in our side lying position, again, treatment leg is mat side, top side. The leg is flexed at the hip and out of the way. We're going to palpate again the medial side of the ischial tuberosity adjacent to the perineal body. So just as our location here. We're going to needle down to the medial aspect of the ischial tuberosity, and then we'll redirect the needle 45 degrees cranially to land on the internal obturator internus muscle. So what we'll do is we're going to palpate ischial tuberosity here. We may find that what we need to do is push that tissue in a little bit so we can gain purchase onto the medial aspect of ischial tuberosity. Then we're going to come in with our needle and needle down onto the medial aspect of ischial tuberosity as well. Once we know our location, then we're going to change to a 45 degree to land into the obturator internus itself.
On to coccygeus. We've covered coccygeus previously. We'll discuss it. You can go back and look at the video aspect on coccygeus. But its origin, the sacrospinous ligament, the ischial spine, inserts into the lateral margin of the coccyx and then the related border of the sacrum. Again, innervation is pedental nerve, and it's pulling the coccyx forward after defecation. Here, this is the one where, so in this case, we're going to be prone. Needle length is 2 to 3 centimeters. There's no real backdrop here. For our procedure, we're going to palpate the lateral border of the sacrum and then the distal aspect and the sacral cornu, the sacral horns. We're going to insert a needle posterior to anterior, slightly lateral to where we palpated the sacral horn to determine the needle depth at the sacrococcygeal junction. So we're going to use that needle to find out where where the bone lies. Once we find that, we're going to move 1 finger breadth lateral until we feel the drop off of the lateral sacral border. And we're going to needle in a piangulation slightly lateral, but no further than 1 to 1.5 centimeters deeper than we had with our test needle. So the important thing here is to be aware of how much of the needle you have remaining whenever you land on to the sacrococcygeal junction. Then as you redirect, you retract and push laterally, you want to go no more than 1.5 centimeters further to land into the muscle of coccygeus.
For the coccygeus, we've covered this previously in the pelvic rotator cuff, but just to review again, patient here can be prone. The person can also be in sideline if we're already treating other pelvic floor muscle in this area. Either way, needle length is going to be 2 to 3 centimeters, and there's not going to be a terminal backdrop here. Our precautions here, the 5th sacral nerve, the coccygeal plexus, and the nerve to levator A9 muscle and the rectum. So here we're going to palpate for the lateral border of the sacrum and then the distal aspect and the sacral cornu or the sacral horns. So here we have our sacral horns. We've palpated our lateral sacral border, which is underneath the ligament here. So we're going to insert a needle posterior to anterior, slightly lateral, where we palpated the sacral horn to determine needle depth at the sacrococcygeal junction. So here's the junction of the sacrum and the coccyx. We're going to drop a needle just lateral to land onto that junction. Then we're going to move 1 finger breadth lateral until we feel the drop off of the lateral sacral border, and then we'll needle in a pied angulation slightly lateral, no further than 1 to 1.5 centimeters deeper than our test needle was. So here we are, our test needle to determine what our depth is. We're going to move 1 finger breadth lateral, and we're going to angulate slightly laterally again and advance the needle no more than 1 to 1.5 centimeters further than that test position.
For that, again, female on top, and the male picture is down lower. Origin, we've discussed this. Ischial tuberosity, the ramus of the ischium, and insertion, female, the crus of the clitoris, male crus of the penis, and it's innervated by the perineal nerve. And again, it's assisted in erection of either the clitoris or the penis. For this, again, we're going to be in that sideline position. Needle length is less than 3 centimeters or 30 millimeters. There's no backdrop here. And again, the same precautions for the rectum, vaginal canal, urethra, inferior rectal neurovascular bundle. So here in sideline, we're going to palpate for the mat side ischial tuberosity and then the pubic symphysis. The needle location is going to be at the midpoint between these 2 points on the ramus. For the female, it's going to be directed medially and posteriorly 45 degrees on a tangent to the ramus. On the male, it's going to be a parallel tangent relative to both ramus. So for the male, we'll be able to use both, you can't see it there, both ramus as our guide. We're not going to try to go internal because we didn't have to. Male ischio-cavernous sits a little bit more inferior below the ramus itself, whereas the female, we're going to have to move a little bit more to an internal direction on that 45-degree tangent there on the ramus.
For the ischio-cavernosus, we'll have different approach for male and female. Both will be in the sideline position. Needle length is going to be 30 millimeters or 3 centimeters or less, and there is no backdrop. Again, the same precautions for rectum, vaginal canal, the urethra, and the inferior rectal neurovascular bundle. In sideline, again, we're going to palpate for the mat side ischial tuberosity and the pubic symphysis. So our location's right here. Needle location will be at the midpoint between these 2 points on the ramus in the female, and it's going to be directed medially and posteriorly 45 degrees on a tangent to the ramus. So female ischial tuberosity, pubic symphysis at the midpoint, we're going to needle 45 degrees posteriorly to ensure that we needle into the ischio-cavernosus right here. So we have to make sure that we go inferior to the ramus itself to land into ischio-cavernosus. Again, midpoint between pubic symphysis and ischial tuberosity. 1, 2, no more than 3 centimeters necessary to land into this tissue. With that, making sure that we're going posteriorly to stay away from the labia. For the male, we're going to use the same ischial tuberosity and the pubic symphysis at a midpoint, but here we're going to needle parallel tangent relative to both ramus. So if we consider our ramus, we want that needle to be parallel to that. So you may have to roll your male patient slightly posterior to needle across inferior to the ramus as the ischio-cavernosus sits a little bit more prominent in the male, and so we can needle through there. Again, no more than 3 centimeters at most, probably 2 centimeters is more than adequate to land into ischio-cavernosus for male and for female.
So we'll move from there to the transverse perineum. And as I look at the clock, I said we would be done. I projected to be 1 hour today. We will not be done in 1 hour since we're well past that. Transverse perineum, male and female. Origin, ischial tuberosity for the superficial internal surface of the ramus is the deeper origin. It serves to the perineal body, innervated by the perineal nerve, and its job is to stabilize that perineal body. For treatment, our approach is, again, in that sideline position. Needle length is less than 30 millimeters, probably 2 centimeters or 20 millimeters is more than enough. There is no backdrop here. Precautions, again, the same precautions. So in our sideline position, again, we're going to palpate for that mat side ischial tuberosity and then the pubic symphysis. And we're going to know, using that, we're just going to note the location of the perineal body anterior to the anal orifice. The needle location is going to be at the midpoint between the ischial tuberosity and the perineal body. So you ignore the pubic symphysis. It's just a guide to help us find the pubic perineal body. So midpoint between the ischial tuberosity and the perineal body, we're going to needle. It's going to be directed laterally and superiorly. So it's going to be away from our internal organs. It's about 30 to 45 degrees away. And again, 2 centimeters, no more than 3 with this approach.
For the transverse perineum, again, we're going to be in the sideline position. Needle length is less than 3 centimeters. There's no backdrop in the similar precautions. Again, we're going to palpate for our ischial tuberosity and the pubic symphysis. We're going to note the location of the perineal body, which is going to be midpoint between the rectal orifice and the vagina. The needle location will be at the midpoint between these 2 points, directed laterally and superiorly, 30 to 45 degrees away from the internal organs. So we find an ischial tuberosity, our perineal body. We can palpate and have our patient perform a pelvic floor muscle contraction to locate the transverse perineum, both superficial and deep at the same time. Needle point will be at midpoint between perineal body, ischial tuberosity, and we're going to needle away from our internal organs.
So again, here we're going to look at a 30 to 45 degree. In my example, it looks more like I'm needling anteriorly. It's really more laterally towards the mat table, almost towards obturator internus is a nice approach to needle transverse perineum. Again, midpoint between perineal body and ischial tuberosity. So from there, we'll look at bulbospongiosis for the female first, and then we'll move to the male. We've discussed our origin, insertion, innervation, and action. So for the female, this is one we will not be demonstrating in lab. We will discuss it. This is the one dry needling approach that requires an internal backdrop. So on the bulbospongiosis, if treating clinically, this will require gloving to use your finger, single index finger, as a backdrop. So we'll place that index finger into the vagina at the midpoint between the perineal body and the pubic symphysis. This is going to serve as the backdrop and allow for palpation of the muscle. Here we want to avoid the labia and the clitoris, and we're going to advance the needle from a lateral to the labia toward your palpating finger as the backdrop. So we're going to take a midpoint between these two structures, pubic symphysis and the perineal body. And as we palpate internally to locate the bulbospongiosis, then we can needle laterally more away from the labia, but then we can direct that needle towards our palpating finger as our backdrop. And it'll end up being about a 45-degree angulation from inferior-lateral to supero-medial. And you definitely don't want to let that needle penetrate through the skin.
The bulbospongiosis for the female. Here we're going to be in the supine position. So position here. And let's give it a little extra support there. Needle length is going to be less than 30 millimeters, and our backdrop here would need to be a finger approximation. Precautions here: the rectum, the vaginal canal, urethra, inferior rectal neurovascular bundle. So for our purposes of our lab, we will discuss this. We will not demonstrate this, If you're in a practice that provides internal pelvic floor exams and treatment, then we can address that as well in a one-on-one situation. For our purposes, it's for demonstration, for discussion only. We'll place an index finger into the vagina at the midpoint between the perineal body and the pubic symphysis. So we'd come in here. This is going to serve as a backdrop and allow for palpation of that muscle. We're going to avoid the labia and the clitoris. We're going to advance the needle from the lateral to the labia towards your palpating finger as a backdrop. So here we would avoid the labia and come in right here. Obviously with our finger at a deeper depth to provide that backdrop as we're approximating that bulbospongiosis in the female.
For the male, here again, supine position, needle length here is less than 1 millimeter. We do not need much depth here. We're going to have our patient use a towel. We're going to have him move his genitals up and out of the way to better expose that muscle. We're going to palpate the perineal body, and needle location will be 1 finger breadth anteriorly and slightly lateral, in a lateral and superior direction away from excuse me, away from the midline. A needle depth will be less than excuse me again, needle depth will be less than 1 centimeter, less than 10 millimeters. Sorry, usually 3 will take care of it.
So on bulbospongiosis for the male, obviously this is a female model, so we'll use our best interpretation to extrapolate this to the male. You can also look at your 3D anatomy application or the slides in the lecture as well to get more detail. But for this, we're using the female model. So here again, supine, our needle length here is going to be 1 centimeter or less. There's no backdrop here. We're going to have our patient use a towel, and actually we're going to be in the supine position. One of the bulbospongiosis, one of the two, or one of the only muscle we really have to do this in the supine position. So keep that person here. And so we're going to have our male subject, we're going to have them use a towel and move their genitals out of the way, up and out of the way, so that we can access the distal end of the penis. Here we're then going to palpate the perineal body. And from here, needle location will be 1 finger breadth anteriorly and then slightly lateral in a lateral and superior direction away from the midline. Needle length here will be less than 10 millimeters. So perineal body, we're going to move anteriorly 1 finger breadth and then slightly lateral. And again, this would be on a male, not the female. Our needle location will be right here. Again, it's very superficial, less than 1 centimeter. To reach our target depth. Again, a very thin muscle, but this is the bulbospongiosis on the male.
Okay, so there is a ton of information that's left to be gone over. Fortunately for us, we've already covered a bulk of all of this information on tendons and ligaments, both of the sacropelvic area and of the hip. So that information is still available for you in the student portal on, there should be the advanced hip or the lumbosacral region. So I'm not going to go over all of these again. We've discussed them. So again, I'm not going to look at all of these, but the linea alba, the adductor tendon, the inguinal ligament, the interpubic disc, obviously all of these have close approximation in and around the pelvic ring that different symptoms could represent either as a differential diagnosis to a pelvic floor dysfunction or in conjunction with things associated with that. The sacrotuberous ligament could be a key one with its insertion or attachment onto that medial aspect of the ischial tuberosity. Most everything that we're doing with the pelvic floor, that is one of our guides, our landmarks there. So I'm going to continue on again. The ligaments around the SI joint, the posterior sacroiliac ligament, sacrospinous ligament, sacral interspinous ligaments, The critical part is that we evaluate where and what our patient symptoms are, use of differential diagnosis to isolate what the real aspect of treatment needs to be. Again, if we can manage to take care of our patient's symptoms without needling the pelvic floor, that would be ideal. But in the event that we need to, we've covered the specifics there. Now let's move on to, and I'm going to make that a little bit larger for me, our Perineural Protocols. We want to talk about our neuromodulation of the pudendal nerve, the tibial nerve, and then our lower intercostal iliopopgastric nerves. We can always throw into the mix, and we should consider it, our cluneal nerves, our lateral cutaneous, iliopopgastric, anterior cutaneous iliopopgastric, which we'll include with our neuromodulation, and the remainder of the nerves that originate in and around that pelvic ring. So we take a look at our cutaneous peripheral innervation of the pelvis, and we see our iliopopgastric, our ilioinguinal, our genitofemoral. Below that, we see our perineal, and then more centrally pudendal. Then we get further lateral, our coccygeal plexus, our cluneals, providing all that innervation. Perineal, S1, S2, S3, being a branch of the posterior femoral cutaneous. Again, the pudendal being more approximated to that midline. If we look at from a dermatome standpoint, S5 being closest associated with the rectum, S4 being more, and S3 more the genitals themselves, and then you can see S2, L3 and L2 on the legs themselves. So for the pudendal nerve, our Perineural Protocol here, our neuromodulation. So the pudendal nerve has origin from the anterior division of the anterior rami of S2 to S4. The branches are the inferior anal or the rectal nerve, the perineal nerve, and the dorsal nerve of the clitoris or the penis. It supplies motor branches, the ischiocavernosus, the bulbospongiosis, and the perineai, and it is sensory throughout the urogenital triangle. And the dorsal nerve of the penis and clitoris is sensory, particularly to the glands. So our dry needling protocol, patient's going to be in the sideline or the supine position. More often than not, it'll be sideline. We'll have to do both sides. Primary neural location is going to be adjacent to the pudendal nerve in an Alcock's canal or the pudendal canal. And we can see that illustrated by the yellow dot. You'll note that's also very similar to where we're going to needle for obturator internus. Our secondary muscle locations will be Pubo Rectalis. So Pubo Rectalis. I don't know why that says the Bulbospongiosis. That should say Pubo Rectalis, not Bulbospongiosis. If you've been paying attention, that is not the Bulbospongiosis. So I'll try to correct that. And so that is what we're looking at as far as neuromodulation of the pudendal nerve. In just a bit, we're going to talk about our treatment protocol for incontinence, and we'll see that neuromodulation of pudendal nerve is actually our third layer of treatment when we're dealing with incontinence. So rarely do we actually need to needle pudendal nerve or neuromodulation of pudendal nerve when we're treating incontinence, because the other two approaches are usually effective at managing it. But in the event that they're not, then we have this third layer here at the pudendal nerve. So for treatment in side lying, the treatment leg is mat side, the top side leg is flexed at the hip. We're going to palpate the medial side of the ischial tuberosity adjacent to the perineal body. We're going to needle down medial aspect of the ischial tuberosity, then redirect 45 degrees cranially to land on the obturator internus. So it's our same approach there for that neural location. For the Pubo Rectalis. We've already discussed how we're going to needle into Pubo Rectalis. I just happened to label it incorrectly. So if you're watching this and I still haven't changed it where it says Bulbospongiosis, that is Pubo Rectalis. That's the wrong word presented there. If we want to get more in depth, we can do our proximal spinal segmental locations up at S2, S3, S4. Okay, this is very busy right here, but if we consider, here's our Pudendal Nerve. As we look, it comes off of S2, S3, and S4, the anterior rami there. And then it comes down and it provides innervation here, inferior anal nerve. It has a separate branch, if I can catch it here, for the perineal nerve. And again, you can see it has different branches as well, out to the superficial branch, and that would make this a deep branch. If I can target that a little bit better. Or there's the muscular branches. So that's where our perineum come from. And then we also have, still off of the Pedental Nerve, well, it's okay, so it's carrying forward. Let's see if we can find its termination there. And that would be the dorsal nerve. And this is a male subject, so that would be the dorsal nerve of the penis, or the female, we would see that as the dorsal nerve of the clitoris. All right, I'm going to stop that share and come right back. So for now, neuromodulation of the lower intercostal and the iliohypogastric nerves, we bring this up to bear. This is a second piece of our incontinence protocol. And so basically here, what we're looking at, our position again, supine, our primary location will be the termination of the iliohypogastric nerve. It's going to be 1 finger breadth superior and lateral to the symphysis pubis. Our secondary location is going to be out here, our internal obliques, external obliques, transversus abdominis, and then let's see here. And then lastly, our rectus abdominis and our lower intercostal nerve. For that, it's going to be, for the rectus abdominis, we're going to be 2 finger breadths caudal and lateral from the umbilicus. So we're just going to drop down that couple of finger breadths lateral and inferior. And so for our neuromodulation of lower intercostal and iliohypogastric nerves, we're just going to have these 3 needle locations. We're going to do it bilaterally. And so we can select for stimulation 3 different channels to address this. Let me come back to Pedental Nerve. Here we're going to do 30 minutes of electrical stim, and it's going to be from 2 to 5 hertz in that range. Here we are trying to see a little bit of a motor response. It doesn't have to be hard or aggressive, but we'd like to see or have the patient feel a little bit of motor response. We'll do for iliohypogastric, similar. We want it about 30 minutes, somewhere 2 to 5 hertz. And then also we want to see that motor response out of those muscles. Lastly, we'll get to neuromodulation of the tibial nerves. And this is actually always our first line of treatment when we're dealing with incontinence. So for this, tibial nerve originates from the sciatic nerve. It, of course, descends in the popliteal fossa, posterior compartment of the leg. It has auricular and muscular branches, as well as the medial cervicutaneous calcaneal, medial, lateral, plantar nerves. So for this, for the neuromodulation of the tibial nerve, our treatment locations, and we're basically just dealing with two muscular locations here. One is the tibialis posterior. Second is the abductor hallucis. In this case, our electrical stimulation is going to be about 30 minutes, and it's going to be at 20 hertz. And we would like to see a motor response out of this. It needs to be tolerable, but if we could see that motor response, it would be preferred. Again, we've covered needling of the tibialis posterior. You can have a either a lateral approach or a posterior approach directly into tib posterior. For abductor hallucis, we're going to needle that closer to the heel on that medial aspect to land into that towards to hit abductor hallucis. Again, 30 minutes treatment, 2 up to 5 hertz, and we're looking, hang on, that should be 20 hertz. So this slide and this slide say 2 to 5 hertz. The protocol calls for 20 hertz for neuromodulation of the tibial nerve. Superior and medial cluneal nerves, we've discussed previously when talking about both the advanced tip and the lumbosacral spine. So we're not going to spend all of this time on that there. Again, it's around the pelvic ring. It could be providing some of the symptoms that our patient is dealing with. So we want to be able to effectively treat that. So we've included that here. Similarly with the inferior cluneal nerves, if you see that's right at the inferior aspect of gluteus maximus. So want to be able to affect some change there. Lateral cutaneous iliohypogastric nerve with the protocol for neuromodulation. We were doing it not necessarily here, but more in its terminal branch. Lateral cutaneous iliohypogastric can be done proximal to the IT band, superior to the iliac crest. Anterior cutaneous iliohypogastric nerve can also be done slightly more anterior. Again, as you can see in the picture represented here, we're doing it 1 finger breadth, 1 to 2 finger breadths, superior and lateral from the pubic symphysis. Lateral femoral cutaneous nerve, again, because it exits at inferior to the inguinal ligament, that may be a nerve that needs to be addressed as well. We've addressed it previously, so we're not going to spend time on it here, as well as the genitofemoral nerve. Again, very close to the pelvic floor there. A similar obturator nerve. And so our Perineural Protocols, the muscular branches of the femoral nerve, probably not as much to do with this, but if we are seeing some pelvic floor issues and we're seeing some symptomology of lack of motor response in the quad, we may want to consider the femoral nerve as well as sensory on the posterior aspect of the upper thigh. That could tell us some posterior femoral cutaneous nerve. From the regional diagnosis protocols. So we're going to lump all of the pelvic floor into 3 issues here. Obviously, there's a lot more that we talked about at the beginning, the thoracolumbar junction, the lumbosacral junction, all of these other regional diagnosis protocols that on your differential diagnosis, your assessment, this may be, you may discover that you need to use one of these other treatment approaches. And it may not be a bad idea if it's questionable which is, try the least invasive, the least uncomfortable for the patient first. Save that pelvic floor dry needling as your last option. So for urinary urgency, frequency, and incontinence, the order of treatment is going to be first our percutaneous tibial nerve stimulation or neuromodulation. Here, so what we're going to do is we're going to have our patient complete an incontinence impact questionnaire. It's an IQ-7. Use whichever format that you would like. What I always use is this incontinence impact questionnaire. And then I'm going to have the patient track their progress with a bladder diary. Ideally, I have them complete their bladder diary prior to coming in for initial evaluation. And then once they've done that, then we can start keeping that on a weekly basis. So again, we're going to start with the percutaneous tibial nerve stimulation, or the neuromodulation. We will progress to the abdominal muscle stimulation or the pudendal nerve stimulation after a month of treatment if there's been no change in symptoms. Here, our treatment protocol is 1 time a week, and it's for 12 weeks. Frequently, our patients see improvement after a few treatment sessions, and it is common to see them drop off and not continue. However, ideally, we have them walk all the way through the full 12 treatment sessions. For slow colonic movement, constipation, and abdominal pain, here we're going to do our neuromodulation of those abdominal muscles that we talked about, iliohypogastric, the lateral obliques, and then rectus abdominis. Again, so here we'll have them complete a fecal incontinence constipation questionnaire, an FICQ, and then we'll have them track progress with a bowel diary. I've got what I use. Feel free to use your own. Look out there. There's different things out there, but that is a great way to monitor progress, to objectify what we're trying to do here. And those tools are fantastic. Here, our treatment protocol is it's twice a week for 6 weeks. Lastly, for fecal incontinence and pelvic pain, we'll do specifically the pudendal nerve stimulation, or the neuromodulation of the pudendal nerve. Again, we'll have them complete a fecal incontinence constipation questionnaire, the FICQ, have them do an initial bowel diary prior to treatment, and then weekly after that. Here, our treatment protocol is, again, it's twice a week, but this can be up to 6 weeks, possibly as far as 12 weeks for fecal incontinence and pelvic pain. When first utilizing these protocols for fecal and urinary incontinence, I wasn't a believer in the fruits of the research that was done. After doing it on hundreds of patients, have seen dramatic results with use even of the posterior tib stimulation or the abdominal stimulation. So look forward to using this protocol and seeing what your results are with your patients out there. Again, we've discussed the TL junction. I'm not going to go through those. They're in our prior lectures. Sacroiliitis, our lumbosacropelvic junction, sciatica. Any of these, the piriformis, could be indicative of some a differential diagnosis that we need to look at to see if it is actually what is our patient's complaint. Again, I would always choose to try something different before directly stimulating, needling the pelvic floor. That being said, it can be a very effective treatment approach when used appropriately. So we've gone through 16 lectures. We've been through our first lab. All that's left at this point, our post-lecture assignment. I'm just going to ask you, number one, name the 2 muscles that are targeted in the first level of treatment for urinary incontinence. And number 2, prepare for lab 2, 3, and 4. We will have a written exam. We'll have a lab exam. And then at the conclusion of that, you'll earn the CHDN certification. I wouldn't fear the written or the lab practical. It's all going to be out of the information that's available through our through the app. So if you don't have access to the app, if you haven't figured out how to use that, reach out, touch base with me, because that's going to be our guidepost as we go through this final lab. So that being said, up next, labs 2, 3, and 4, the written exam, lab practical, and our CHDN certification. We've got our next one in about 2 weeks. So enjoy going through this last lecture. Apologize for some of the technical issues we've had doing this off of 2 side-by-side laptops. but I think we got it done close enough. Questions, issues, let me know. Otherwise, bid you adieu, and we will see some of you in 2 weeks.